Critical care is a very delicate and very expert-driven unit. You're constantly monitoring patients, and you're constantly having to see what is happening with this patient moment to moment, because at any one moment you need to intervene and save life and maintain life and then strengthen that life to be able to leave that ward. We also have admin costs. Like I mentioned, we have utilities, stationery, the run-of-the-mill, the sports staff, the infection prevention and control, a whole manner of administrative costs that go into maintaining the operational costs of a tertiary hospital. And then, of course, imaging, and that is really scanning and making sure that we're keeping on top of what is happening with our patients. When our health workers fall sick, we of course offer them care in our facilities, honorable members. However, we then need to hire locums to fill in the gap of where they've been caring for our patients on our wards. So there you bear the cost of sick leave for the human resources in health that we're caring for, plus the cost of their care, but then plus the cost of the locum that you have to hire to fill the human resource gap. And then they're having to review them, and then they're having to check on them, and then you have cleaners coming in to clean, and they have to be in PPE, and we have to manage infection and prevention and control. That in itself, ladies and honorable members, drives up the cost of care. While we wait for the connection to come, I'll keep trying to walk you through. Then we get into the laboratory costs, and through key indicative investigations, we need to make sure we're looking at their liver function tests, their renal function tests. We need to look at their complete blood count. We need to do cultures. We need to basically make sure we know on a micro level what is happening with this patient at all times, and at times several times a day. It is not like malaria, where you can do a malaria test and then you know how many malaria parasites that patient has on a slide. We need to make sure that we're on top of this care because it is critical care. Then lastly, when we get to admin costs, we're looking at overhead costs, indirect costs that are shared across the whole facility. We found a spike in utility costs. Our water bills have gone up by 25%. Our electricity has gone up by 45%. Facilities are paying $57 million per month for electricity. This is very aggressive, especially, like I mentioned, you're unable to spread it. For example, now in a lockdown, across other visits. And then, of course, we have the laundry and catering. And these are the hidden indirect costs, making sure that you have properly disinfected laundry available at all times for all patients and staff, and obviously gowns. And then, of course, catering to make sure that you have meals available for both staff and patients. Maintaining standby generators. When we have, as we know, at times electricity can be a little unstable or the voltage can be a bit low. We need to make sure that we have on standby fueled generators 24 hours a day at all times. And fuel is expensive to be able to support this equipment to be online, as I said, for up to 20 consecutive days or upwards. And then, of course, equipment servicing and maintenance, as I mentioned, and staff transport, as well as on-site lodging where we can for our health workers. All of these honorable members are what are contributing to some of these costs, and that is excluding any CT or angio or X-ray radiology that needs to be carried out on the patient to see what is happening inside, to see what the progress the patient is making, and of course, disinfection of the areas that we're managing.
Let me give you my experience this past month of what I will not name the facilities where this happened. A relative of mine, a doctor at that, her mother contracted COVID and ran out of oxygen from one health facility and approached one health facility. They said, no, we can get you a bed, but you must put advance payment before you bring your patients here of $5 million. At 5 o'clock, we drive to this facility. The patient's admitted. 2 hours later, the patient's dead. We say, can you refund at least half the money? He said, no. What is that you have used in the 2 hours to cost the $5 million? You can't even have the courtesy, the human heart. Or this person was going through this. The next one of another relative, and we talk this with pain, and we ask you to have a human heart. A patient in the hospital is mismanaged. They say, no, take your patient elsewhere. And how can a hospital send, after paying $8 million, on the way to the next facility, the person dies. What do you want the Ugandans to say about you? I had my uncle admitted for 22 hours, paid 8 million. I said, can you give us a breakdown? What has shocked me was when they gave that there was an injection which costed 3 million. What's that drug which cost 3 million? An injection. For someone who had just lasted that hours and it's gone. So if we had spent more than the 22 hours, I don't know what the cost would have been. Well, so we only ask the medical and the private medical practitioners that please, even if you have to make profit, have a human heart.
Professionalism. Is it true? We saw State House. State House has its own people who move around. They arrested the people giving fake vaccines in private hospitals. Then I had to call those who vaccinated me. Those from Mulago, I think they were from Mulago cases. I said, you people, why did you vaccinate me with the water? They said, no, ours is not that one. But that was a private hospital. Have you followed that? Have you taken keen interest as you practitioners to find out those particular people who are tarnishing your name? Then lastly, when we hear that a private hospital, you don't have money, but you have a land title, or you have a car, what car? I have a RAV4, bring it. Is that true? And does that promote professionalism in the hospitals? How do you manage that, and how do you stop that? Give us facts about that. Mr. Chairman, Novik was one of the first hospitals, I don't know who comes from Novik here, to give vaccines for hepatitis at a low cost, 20,000. And indeed, most of us flocked there. Mr. Chairman, as we talk now, still Novik came out with 80,000. They were the first ones, I think. They put it on social media for COVID test. Now, when I go to Villa Maria Hospital, where I come from, the only hospital in my district, they're also charging 80,000. But the man there is saying that they are charging them 25 packs, cost 950,000, hence arriving at 80,000. However, the charge before was around 250. Then Novik came out very fast for that cost. Where is the problem? Because, Mr. Chairman, if you don't give us facts about what is affecting you to raise those charges, we shall not get an answer from you. We shall not get a remedy for this problem. Is it taxation? When you talk about the high costs, for example, Mr. Chairman, when you go to Lacho Hospital, it is the story everywhere that Lacho, even if a patient is put on oxygen, because they have an oxygen plant, they are charging 500,000 for a patient at that cost. What is causing that? Do you want to bring in machines to put oxygen plants at your hospitals, but URA's charges cannot permit you to do so? Tell us that. So that if we get that, then we get URA and put them to task.
Yes, I think there is a difference between antigen and PCR. So we need to correct that and verify, because it will help us also in our, I think the cost you were saying was antigen. I verified with Novik. Yeah.
For us, we are not medics. We know they are testing us COVID.
Okay.
So when they are testing me through the nose, I know they have tested.
Okay.
So, and their results, whether they are wrong or correct, what they give me is what I take.
Yeah.
But I minded about the cost.
Okay. I was just answering the
I was praising
yeah.
Novik, by the way. I was coming from the highest charges to 80.
Okay.
And when I looked at Kalungu, where I come from, it is 80. Then I rang Zambia, it is 70, which is relatively fair.
Yeah.
So that's what I was saying. Otherwise, for us, we don't know those medical words. I don't want to tell lies about that.
Thank you, Honorable Member. I just wanted to verify why the difference in costing is there for 250 and 80, such that we are very clear on that as well. A third, the other narrative that was thrown around was the costing, the disparity in costing for the hospitals. I think that was just wrong of the media, because they weren't very sure of the information they were sharing, and they just shared. I'll tell you because they called all of us. Some of us talked to them, some of us didn't talk to them. So I think the honorable member behind was very passionate in her speech when she said some people are charging 10 million, some people are charging 2. And I think that wasn't true. It was just something that was released in the media. I also saw it, but it wasn't true. And I actually castigated them when they visited my office. And I told them, you guys, you need to be sure about some of these things because they have ripple effects.
Chair,
yes.
There could have been that which appeared from one of the hospitals I don't want to name. Leave alone what the newspapers or social media, there was a letter from a hospital, and that hospital did not deny that such which was given to that patient.
I was making a comment on the costing, not the letter.
Yeah, it was costing. Yeah. It was giving the cost and totaling to the total amount that's needed per day. In fact, I was trying to look for a copy before I came here, but I didn't get it.
Sorry. Yes.
The key drivers to these costs. And if we address the key drivers, we are able to manage the cost of this pandemic. The first key driver is ventilators.
Is what?
Ventilators.
Yes.
As you realize that we were managing ICU patients before. But even with this pandemic, it doesn't mean that the normal ICU patients are out. So what does that mean? You find that average of us manage maybe 6 patients of ICU. We have to acquire ventilators. In a cost of a ventilator now is at an average of $30,000. But because majority of us are running on overdrafts and loans, which we have restructured more than twice since the pandemic, you are left with no option but acquiring through loans becomes a problem. You're already overdrawn, so you have to go for an option of hiring. Hiring a ventilator currently in the market is at an average cost of $600 at cost price. Before any...
Can you speak in the microphone because those are important points you're making?
What I was emphasizing that the cost of ventilator is currently at an average of $30,000. If you have 6 ICU beds, you need $180,000. Which 180 you are unable to get it from loans because yes, we see in the papers that the CBR rate has been reduced, but it's not what is happening in the market. What is happening, you find the rates are still on the higher side from the commercial banks. So what does that imply? That you are unable to purchase a ventilator, at the same time, you cannot go to the bank to look for it. So you have to hire the ventilator, of which the hiring costs is $600,000 at cost price per day, not per the whole entire lifestyle of the patient while in the hospital. Now, at $600 before adding any markup, it pushes the cost of management high. The second one is on the oxygen. Before COVID, average hospitals here, we used to have average of 30 cylinders or 40 cylinders. As we speak now, we are in an average of 100 cylinders. That even facilities which had the plant, the purity level needed to manage a COVID patient is at 100%. So you need a cylinder. So we had to buy cylinders. Cost price average was, we started with 1 million until they even reached a cost of 2 million per cylinder. But that does not have oxygen. So you have to refill the cylinder, which average rate to refill is 60,000. Now, based on the medical team, an average patient in COVID ICU takes 8 cylinders. Now, 8 times 60, that is 480,000 at cost price, before any markup. Now, there is a transportation cost. There is also need to see how you can recover the payback period of the cost of the cylinder itself, which as we have agreed that can go as longer, but you look for the options. That drives a cost. Already at cost price, that's already in 1.2. You got PPEs. If you analyze the numbers we use, I'm using 7 ICU beds. 7 ICU beds, an ICU patient has an attendant nurse. A patient, a nurse. On average, if you have 7, with the guidance from Ministry of Health and WHO, it's not required to have a nurse work for more than 8 hours. Has to change the PPE, meaning you have to replace the team. So if you have 7 beds, it means that in 24 hours you need 21 nurses. But all these nurses require a risk allowance, which has to be paid instantly. Now that figure pushes the cost of managing to, and in addition to the risk allowances, all these nurses have to be provided for PPEs, which PPEs are costly on our side, in addition to other specialties who are managing these patients. So if there is an option that we can acquire all these PPEs, based on the statistics we can share through our federation, I believe that it can reduce the cost of managing. Even within the process, you try it maybe, because from the guidance of Uganda Medical Council and the rest, we are allowed to refer to the public health facilities, but you are not able to refer because there is no bed. So if you have incurred the cost of managing, but recoverability becomes a problem. So maybe my request, since we are here, is that if possible, we highlight them, because as I speak now, we have a lot of bad debts arising out of people failure to pay. And two, the pandemic may end, but 2-3 years down the road, you get URA audit, and the bad debts are not allowed for tax purposes, that you did not do the necessary steps to recover the money. But when it is arising out of this, so you find the cost of treatment incurred 80 million, 90 million, but the situation is worsening.
In view of the outcry that has been going on in the country, and in view of the bills that we've seen in the internet, either true or not true, to me, it borders on unfair charging of patients. And whereas you are doing a very good job, the moment you lose the professional aspect of it, then you've lost the whole argument. Because if you go to an extent of retaining patients because they have not paid you, if you go to an extent of retaining dead bodies because their relatives have not paid you, despite even having a payment arrangement available to you, then you know you've lost your argument. If you go to the extent of saying that, you see, we are only treating 2% of the population, so we can charge them in any way we want, you know you have lost your argument. And on professional basis, because then you've deviated from what all of us swear, that we shall do the best for our patients, that we shall not overcharge them. So that is my first point that I would like to make, that just by the nature of the bills,
I think that you have made.
The nature of the how we've conducted ourselves, that Uganda is charging lowest compared to other East African countries. I wanted to see the comparison. This is what ICU in Kenya is charging. This is what Tanzania is charging. But it was conspicuously absent. I expected you to give me a comparison that before COVID, these were the costs of utilities. National Water was charging us at this rate. Now, all of a sudden, they have increased by 45%, or 15%.
I would like to probably start by drawing our minds to the realities on ground. And what do I mean, the realities? Uganda is a country that has a population of about 45, according to the last census, million people. And maybe as I talk, it could be 48 or so. And I'm just looking at critical care in this country. The number of functional ventilators in private facilities that we are talking about currently are about just 40 to 50 for COVID cases. 45 million Ugandans, 40 to 50 ventilators. The PNFPs probably have about 40 ventilators, maybe 20, because the number cannot actually be 40, 20 functional ventilators. Until about 2 weeks ago, I thought Lacho Hospital had 6 functional ventilators. But now, after losing a colleague in the process of transferring them to Kampala in order to have them access a ventilator, came the realization that that may not be the case. Government has about 20 to 30 functional ventilators. And when we go back then to the human resource, who mans these ventilators? Intensivists in this country are about 75, the whole country, the whole Uganda. And northern Uganda, where I come from, has about only 3 intensivists for the entire population. This is the reality of ICU care when you break it down to that 1 to 2% that actually needs it. When we go back to then look at who actually needs it and why is that outcry so much more currently. Earlier on, a lot of this cost was actually being incurred by insurance companies that provide the 40 to 60% care that we talked about in private facilities, because you realize that a lot of the ventilators we're talking about are actually in the private facilities. With the COVID-19 pandemic, insurance companies are not covering the cost. So the cost is going back to individuals. That cost has been high even before COVID. That was the reality. I'm yet to know a functional ICU that is running ideally at 2 million shillings, even before COVID. That's the reality on ground. And my colleagues have labored to mention quite a lot of things and reasons why. There are so many things when a patient is in an isolation unit or just a ward that you may get away with not doing. For example, you can do a CBC once in 3 days, and that will be okay. You can do a radiology investigation like a CT scan maybe once in a week, and that will be okay. But once you get into an ICU setup, things change. Sometimes you need the CBC 3 times a day in order to make an informed decision. And when you don't do it, then problems come about. And you do not want to be able to mismanage your patient or to give care less than what is expected in an ICU setup. So ICU care is really for that 1% previously of the population because of the nature of diseases that we were seeing then, but currently has been aggravated by the nature of the pandemic that we're facing, the COVID pandemic. And more so because previously we were talking about the Alpha variants, now we are talking about the Delta variants. What has been the research? What has been noticed about this particular variant? The fact that ICU cases tend to be more critical. And because they're more critical, then the number of people who are going into ICU are actually more. So patients come in, they're way more sick than we were seeing before. They need ICU care, they need several doctors, they need all sorts of medications. And this has been compounded by so many other things. Mass use of the antibiotics we are talking about. So perhaps I can actually take the time to just try and explain what happens when we use these drugs, and at the end of the day, the results that we see as far as ICU care is concerned. One, if a patient utilizes something like azithromycin from the pharmacy or amoxicillin, and then eventually by the time they come into the hospital, they have probably used penicillins, they have used azithromycins, they have used maybe the cephalosporins and all the other drugs, the ceftriaxones that we see every day people, utilizing on the street. By the time you enter into an ICU setup, chances are that workup that says you're resistant to several drugs. Just this morning, I was sharing a profile of a patient to some of my colleagues where the patient was literally resistant to every drug I knew in the book, minus polymyxin. And even then, it was just showing pending.
Doctor, we have traveled all over the world. Almost the medicine you are talking about are not available at the counter. They are only available on prescription. Why are you people allowing people to go to the counter and buy these drugs?
Thank you.
Because you see, pharmacists, yeah, and you tell me any drug now, and within 10 minutes they will bring it here for you. Why? Because these pharmacies are busy. It's all about money. And I think there's a problem. Many countries, there are drugs which you can't get over the counter unless you have a doctor's what? Prescription. Unless some of your colleagues are actually prescribing these, some of them. And then when you reach to an intensive, whatever, that one. When you reach that one, then it says, now you see, you've been taking these drugs, now your system is resistant.
Thank you so much, Honorable Chair. I was trying to drive this point home with the very hope that I would basically bring into discussion exactly what Honorable Mr. Chair has just said. If we do not have regulations in place for the drugs, especially the essential drugs that we use, then definitely this quagmire that we are in is bound to happen. Regulation of essential COVID-19 drugs. I mean, we cannot sit back and not make any effort to at least try and do some regulation for these essential drugs. And a big list has been given to Grace, and she's shared it with so many actors with the hope that once we regulate the costs, regulate the prescriptions, then probably we can get back to a place where we can comfortably use drugs as we should be using them under the prescription of a medical practitioner. Beyond the regulation, of course, is the information. And I think this is what we are doing for the several weeks, making sure we are educating the public, making sure we are passing on information that it's not enough for you to just go to a pharmacy and buy amoxicillin. It's not enough for you to go to a pharmacy and buy dexamethasone, because I bet after the COVID pandemic, we're going to start dealing with the challenges of the dexamethasone use that is rampantly being prescribed all over the place.
As a Uganda, of course, it is like my own country also, because we are working here, we are living here with my old families also. Why not we are allowing the other vaccines to come in the Uganda? You know, the AstraZeneca, which is there available, the manufacturer has recommended in the UK, if you are above 40 years of age, go for AstraZeneca. If you are below 40 years of age, it is better to choose another choice also. Why we don't have so many choices here? And if private sector is ready to import and to improvise these vaccines to the community, I think we should allow them. We should allow all those people. Yes, government can be there to monitor the prices. There is no issue. You can be there as an inspector to monitor the prices. Allow them to go carry on also, because there are so many who wants to, who can afford also, who wants to take also. Let them import and get this. We are buying. Then we also got a day, we bought in 60,000 also. So these are those factors which you can control very easily. We have no control on them also. So there are some regulations from the drugs also which will benefit the civilians indirectly, I am sure also. About the vaccination, I said clearly, we have some resources, we have some assistance also.
Do you have vaccines on the market which you people can access?
Yes, we can access.
Is that so? Because the government has been saying that most of the vaccine has been overbooked.
I want to find out from these practitioners, what does it cost and how expensive is it to assemble a bed? We have information that the government bought beds, but they have failed to assemble them because they need a lot of money to assemble them. And we have seen your hospitals, they have those expensive beds. Mr. Chairman, yesterday on TV I watched one of our media showing us a company that has produced 45,000 beds, and the assembly was not very difficult. Mr. Chairman.
Information, Chair.
No. We will handle it. But
Can I?
Yeah, you know, the issue about beds is not the literal bed we sleep on. When there's an ICU bed, it is a complete, infrastructure with ventilators and so on. So I think we need to put it in context when we talk about beds. An ICU bed, an HDU bed, and then a bed on an ordinary ward. It goes on. There are different beds. It's not really about a structure where people sleep.
Yeah, Mr. Chairman, why I have not gone to the nitty-gritty of the bed and the details of the bed. I know these people are always watching news every day. And when I talk about what has failed to take place, I want to find out, because the Nakasero cannot fail to have an ICU bed. So what does it cost you? So that we learn why government is failing to put all this in place.